Good morning, everyone. Welcome to Grand Rounds. My name is Rebecca Muley, and I'm one of the Grand Rounds co-directors, along with Dr. Adi Talati and Dr. Alex Harris, who is joining us remotely. Welcome to Grand Rounds today. Next week's Grand Rounds on February 14th will be presented by the Office of Equity, Diversity, and Inclusion in honor of Black History Month. Dr. Deidre Englund, Associate Professor in the Department of Psychology and Clinical Psychology at the City College of the City of University of New York, will be presenting Structural Racism and Social Determinants of Psychosis. So we all hope you can join us for that. It will be a fully remote presentation. Before we introduce today's speaker, I'd like to encourage everyone joining us to post questions at any time during the talk using the Q&A feature at the bottom of the Zoom window, and which is separate from the chat function. If you're a trainee, please put the word trainee at the beginning of your question, as we'd like to prioritize trainee questions both online, and there will be a special shout out for trainee questions here in person as well. If you write "Can't ask question myself," we will be able to promote you via the panelist function so that you can actually ask on the video camera for Dr. Huey. Another note, at the conclusion of the Grand Rounds, there will be a trainee lunch for Dr. Huey to meet with those who have reserved a spot. Please note that this lunch and the discussion are for our trainees to have an opportunity to discuss with Dr. Huey. And so any faculty that would like to meet or speak with Dr. Huey, please use the Grand Rounds email to let us know that you would like to contact him further. Today's Grand Rounds is going to be a very special one. It is the Viola Bernard Grand Rounds. And we are pleased to have Dr. Stanley Huey, Associate Professor at the University of Southern California, presenting his talk. Dr. Laura Mufson is going to be introducing him. She is the Viola Bernard Professor of Medical Child Psychology and the Interim Director of the Division of Child and Adolescent Psychiatry. Please welcome Drs. Mufson and Huey to our Grand Rounds today.
Thank you for coming. It's nice to see so many people in the audience and on Zoom. Before I introduce Dr. Huey, I would like to say a few words about Dr. Bernard. Dr. Bernard was a prominent New York psychiatrist and psychoanalyst who was on the faculty here at Columbia for 5 decades. Throughout her professional life, she worked to expand the application of psychoanalytic theory to study and address social problems that she saw as negatively impacting the mental health, particularly of children. She was ahead of her time with a focus on the social determinants of mental health, and she founded the Division of Community and Social Psychiatry here at Columbia, and she directed it from 1956 to 1969. Dr. Bernard was committed to understanding the needs and problems of children who were suffering due to poverty and other social and community factors, and she was committed to increasing their access to mental health care. She established the country's first low-cost psychoanalytic clinic at Columbia as part of her campaign to make mental health services much more widely available. In 2016, the Viola W. Bernard Foundation made a generous gift to Columbia to establish the Viola W. Bernard Endowment Fund, which supports this yearly Grand Rounds presentation, as well as trainings and evidence-based interventions for children and families that we provide to the community. And since COVID, we have not done so much of that, but we are looking forward to re-energizing our training program. So I am honored today to introduce Dr. Stanley Huey as our Viola Bernard Grand Rounds speaker. As you will hear, his work embodies the same mission and goals of Dr. Bernard. Dr. Huey is an associate professor of psychology at USC with a joint appointment in American Studies and Ethnicity. He received his BA in anthropology and psychology from UC Berkeley and his PhD in clinical psychology from UCLA, a true Californian. He did venture outside California to complete his APA-accredited internship at the Medical University of South Carolina's Department of Psychiatry and Behavioral Services, and then he returned to California and joined the USC faculty in 2000. Dr. Huey's research focuses on reducing disparities in behavioral health by optimizing treatments for ethnic minority and high-risk populations. Much of his research tests assumptions concerning ethnicity and psychotherapy effects, with a particular focus on the effectiveness of culturally tailored treatments, which is what he is going to talk about today. Dr. Huey's work spans the conduct of randomized clinical trials, as well as he conducts a number of meta-analyses examining the effectiveness of evidence-based interventions for diverse communities of color. His work is published in top journals, including the Journal of the American Academy of Child and Adolescent Psychiatry, the Journal of Clinical Child and Adolescent Psychology, and the Journal of Consulting and Clinical Psychology. And he's presented widely both in the US and abroad at international conferences. His research has been funded by the NIMH and the American Foundation for Suicide Prevention, as well as private foundations. Dr. Huey also teaches many classes addressing mental health and diversity, as well as supervising psychology graduate students on their research, as well as behavioral, cognitive behavior therapy, and family-based treatment. And he has mentored countless undergraduate, master's, and doctoral level students at USC. And I am very excited for his talk today titled Evidence-Based Treatment for Culturally Diverse Populations, Does Cultural Competence Matter? So give me a round welcome of applause.
Thank you, Laura, and thanks for that nice introduction. And yes, did you say proud Californian? Something, yeah. And also a grateful beneficiary of the largesse of the taxpayers of California who've heavily subsidized my education in the University of California system. So I want to give a shout out to the California taxpayers for helping to educate me for virtually free. Sometimes I'll point out how my last year at Berkeley as an undergraduate, my tuition after the Pell Grant, before the Pell Grants kicked in, was like $1,500. So I am very, again, thankful for the public sphere for helping to educate me. Thank you again for the introduction and inviting me here today. I have nothing to disclose. I've learned to give these disclosure slides at the very beginning. So, setting my timer here because I can talk a lot. I'm going to talk about something I really like talking about, and that's making evidence-based treatments fit for the diverse populations that need them the most. And nowadays, let me just adjust. Escape. Okay. All right. So I'm a lot more open about my personal motivations for doing this sort of work. My younger brother had significant behavioral and emotional problems, mental health problems, substance use problems as a kid, and then as an adult. Sorry, hold on. Okay, got it figured out. And he spent a lot of his early years in juvenile justice facilities, and then later in the public mental health system and in the criminal justice system. Is that me? Am I doing something bad? And then a few years ago, he committed suicide while incarcerated. And I don't blame our public mental health system, but I can't help but wonder if the system was more responsive to his needs, whether he'd still be with us. So when I give this talk nowadays, I think I sort of do that with his sort of memory in mind. So let me give you sort of some context in terms of the sort of the foundation for the rest of this talk. back in grad school in the 1990s, I went to UCLA as a grad student, and Antonio Polo and he was a fellow grad student in John Weiss's lab in the early 90s. We started to think about whether psychotherapies work with ethnic minorities and what role culture played. My advisor was kind of an expert in kind of meta-analysis, child psychotherapy outcomes. He was also doing this emerging work, trying to address what he called the gap between the lab and the clinic. We had all these so-called empirically validated treatments, that's what they were called at the time, that seemed to work at addressing depression, anxiety-related problems, conduct problems, et cetera, in youth with significant mental health problems on the one hand. On the other hand, we had kind of a hodgepodge of things going on in the real world. And the evidence that we had to date suggested that they weren't working terribly well. There weren't a good number of randomized trials at the time in the 1990s sort of showing that, but the few that were there suggested that we weren't really getting good effects. So what's going on so that we have these really cool empirically validated treatments on the one hand in lab-based settings, but they're not in the hands of people who are doing this in the real world. So Antonio and I were thinking, okay, well, we're learning all about these empirically validated treatments, but we're also learning about cultural competence, cultural tailoring, and Stanley J, kind of a pioneer in this work on culture and psychotherapy, was on faculty. So he developed this perspective called the cultural responsiveness hypothesis. And it basically argued that there are some real challenges with these conventional treatments and with evidence-based treatments in particular. Some of the big problems were developed primarily by white, English-speaking individuals. Most clinicians at the time, that's the case now as well here in the United States, most clinicians were white. And many of these interventions didn't consider the beliefs, the worldviews, the language, the perspectives of culturally diverse folks. And the thinking is that when culture is ignored in the clinical context, you're going to have a cascade of problems. There's going to be values conflicts and miscommunication between the clinician and the client. If that happens, clients are going to be more poorly engaged in treatment. There's going to be more discomfort on the part of the clinician. And if they're uncomfortable, if there's poor engagement, then they're going to drop out. And if they drop out, they're not going to benefit from these cool interventions that we have to offer. So there's going to be poor outcomes. So the thinking then was that your interventions had to be culturally responsive to meet the needs of the client population, or the clinicians had to be culturally competent. And preferably both. The interventions tweaked in a way that makes it match optimally the folks you're working with, and the clinicians are good at bobbing and weaving and kind of titrating and modifying on their own to match the needs of the client. So our thinking, Antonio Polo and I, was that, hey, you know what? We can do our own meta-analysis to try to assess whether these interventions work well for ethnic minorities. So these are the questions that we started to ask in grad school, and we decided to do our own meta-analysis, not realizing how challenging it would be, in part because if you look at abstracts and titles, at least as they existed in the 1990s, most of the studies that included a large percentage or a majority or even exclusively ethnic minorities, they didn't have anything in the abstract or title saying that, indicating the ethnicity of participants. So we found that we had to actually do a hand search of thousands of randomized trials before we could cull the 30 plus studies that we needed for a meta-analysis. So it took us way longer to do the meta than we expected. But we'd asked these questions, and we thought we knew the answers to each of the questions. Are mental health treatments effective for ethnic minority youth? We thought, well, maybe sometimes, but often not, because these interventions weren't developed for youth of color. Do white youth benefit more than minorities from the same treatments? Well, of course, Euro-Americans are going to benefit more than Euro-American youth. And do cultural adaptations enhance outcomes for ethnic minority youth? And we thought, well, yes, definitely they will. So turns out the data started to change my mind about the role of conventional evidence-based treatments and the role of cultural tailoring. And I think this is how hypothesis testing in science is supposed to work, right? You come in with a certain set of assumptions and you think you know the answer to them, but you set things up in hopefully a fairly, at least semi-rigorous way to offer the possibility that some alternative hypothesis might be true. And then you find that things are way more complicated than you thought. And that's kind of what happened in my case. And I'm going to talk about some of that complexity today. And it is complicated. I'm going to try to make it as straightforward as possible in the next 35, 40 minutes. So these are the 4 questions I'm going to try to address quickly today. Are treatments effective with ethnic minorities? Are treatment outcomes worse for ethnic minorities compared to Euro-Americans? Does cultural tailoring enhance treatment outcomes for ethnic minority populations? And then finally, given the tentative answers I'm going to give to those first 3 questions that are going to create a certain amount of skepticism, I'm going to ask and try to address whether cultural tailoring matters, whether culture matters. So let's start with the first big question. Are therapies effective with ethnic minorities? And by therapies, I mean mental health interventions for folks with existing mental health problems. But before I answer that question, I need to give just a very brief primer on meta-analysis, although I'm sure most of you know already. What is meta-analysis? Basically a quantitative review of a literature, in this case, psychotherapy outcomes with ethnic minority populations. And we focus on randomized trials where folks are randomized to some active intervention or some comparison condition, typically a control condition, sometimes placebo, sometimes waitlist, no treatment, sometimes another active treatment. And for the data I'm going to be presenting today, it's going to be an active psychotherapy compared to some sort of control group, not another active intervention. And then you calculate something called an effect size that gets at how robust the treatment is relative to a comparison group. And basically, you take the average outcome at post-treatment or follow-up for the treated group, subtract from that the average outcome at post-treatment or follow-up from the control group, and you divide by something called the pooled standard deviation. And if you get what you're angling for is a large effect. You want, when you're providing these interventions, for the effects to be as robust as possible. Large effect is what you're angling for. But honestly, if you look at the larger psychotherapy outcome literature, medium effects are the norm. So if we get something in the 0.5, 0.6, 0.4 range, we're good to go there too. Not as great as large, but medium effects are good too. And then 0.2 or so is a small effect. Now, that's okay too. That's better than no effect at all. But really what we're hoping for is something in the medium to large range. So I'm giving you these numbers just to help anchor you to what the effect sizes are that we're hoping for in the meta-analysis results that I'm going to show you in a minute. So one thing you'll notice is that at the bottom, I'm going to give these sort of citations. And when you see a name bold, it's either a current lab member, a grad student in my lab, or a former lab. And it's kind of a reminder to me because I don't give shout outs enough to folks in my lab. In fact, my grad students have had to remind me in the past about how poor I am, despite the fact being trained as a behaviorist, how poor I am with the positive reinforcement thing. So I need little prompts to help remind me of how wonderful and how great my students have been and how they've helped on my productivity trajectory. So when you see bolded names, former or current graduate students. So here's some data from some of the meta-analyses that we have ongoing in my lab or that we've completed. And you see that there's some variation here. So the largest effects that we found are for Asian Americans. We found something close to a large effect size in a meta-analysis we published in in 2018 focused on psychotherapy outcomes with Asian Americans. And what's really interesting about Asian Americans and randomized trials is that there were essentially no RCTs prior to, say, 15 years ago, just a desert of RCTs. But what's happened over the past 15 years or so is you've had about 25, 30 randomized trials conducted in that small period of time that allowed us to put a meta-analysis together showing that you get pretty good effects, better than most meta-analyses of treatment outcome effects. In terms of Latinx youth, a meta-analysis we're working on about a medium effect. The meta-analysis we published in 2008 focused on evidence-based treatments for ethnic minorities, 0.45 effect. Others that we're working on or that we've completed for ethnic minority youth with conduct problems or substance use problems, 0.7, 0.37. So ranging from like small, medium to large-ish. And then this is taken, this is a figure from a paper we published in 2014 in Annual Review of Clinical Psychology, where we took randomized trials in our database, about 140 randomized trials, and separated them by mental health problem to see what the effect sizes were across those different problem types with a broad array of psychotherapies or interventions. And we found, again, a lot of variability. So the largest effects for anxiety-related problems and schizophrenia and sort of trauma-related problems, the smallest effects for smoking, substance use, and miscellaneous others. But when you average across all of these, you get about a medium effect. So a range of small, medium to large, overall, averaging across all of these studies, about a medium effect. And then this is taken from our most recent paper in Annual Review of Clinical Psychology, where we looked at published meta-analyses of cognitive behavioral interventions with ethnic minority populations. And we see even more variability in terms of outcomes. But again, if you average across these, you get something like a medium to medium large effect in terms of interventions for CBT interventions for ethnic minority populations. So when you kind of look kind of more broadly, the data suggests that we have at least 60-ish kind of different manualized-ish interventions focused on intervening with ethnic minority populations, ethnic minorities with a broad array of mental health problems. All sorts of interventions, family systems interventions. I spent a lot of my early academic years in the multi-systemic therapy world. So that one really important family-based intervention for kids in the juvenile justice system. Interpersonal psychotherapies, a lot of evidence that they work quite well with youth of color. And adults of color. There are a number of trials. In fact, we are doing a meta-analysis of eating disorders interventions, and maybe about a third of the studies we found so far with for eating disorders or IPTs. And then a diverse array of CBTs, cognitive behavioral interventions, have efficacy. And then just infant-parent relationship therapy, motivational interviewing, play therapies, and all sorts of therapies. One really interesting factoid, and if I ever have time, which I probably won't, I'm going to do a meta-analysis of this too. It turns out the modality doesn't seem to matter that much. So one argument that some scholars have made is that, well, if you do group-based interventions, peer-based interventions, family-based interventions, then that allows you to better see or discern the cultural context in which youth and adults of color are embedded in, and the clinician can then do their tweaking, modifying, et cetera, because they're better able to see kind of how interactions work in this family or peer or group-based context. So those kinds of interventions should be more effective because they allow you to better see the context that youth are embedded in. It turns out that in those studies, and we found about 15 or 20 so far that include predominantly ethnic minorities, those studies by and large show that individual therapy compared to group, compared to peer-based, compared to family-based intervention, compared to parent and child-based intervention. So interventions where you have families involved and maybe a youth component too, it doesn't seem to enhance. Having the parent involved in intervention doesn't help, on the surface at least, when you look at effect sizes. It doesn't seem to enhance above and beyond individually based treatment. So I've got some hypotheses about that, but anyway, so what do we know? Well, overall, evidence-based treatments exist for ethnic minorities with a broad array of mental health problems, antisocial conduct problems, anxiety, depression, psychosis, PTSD, substance use problems. There are big gaps in the literature. I don't know of any studies, and I've talked with folks who are involved in the world of intervention with bipolar disorder and autism spectrum disorder. No RCTs yet that I know of. The landscape is changing with eating disorders. Again, we found somewhere between 10 and 15 so far, although most of those don't focus on folks with full throttle eating disorders, but folks with kind of a threshold number of symptoms, basically. OCD, personality disorder. So we've got a lot of data now, but we've got lots of gaps still in the literature. So answer to the first question, are evidence-based treatments effective with ethnic minorities? Well, yes. And the data is pretty overwhelming at this point. But just because they're effective with the ethnic minority populations doesn't mean that they work equally well for them. So thus we have our second question. Is there differential effectiveness? And particularly, do Euro-Americans benefit more than ethnic minorities? So I'm going to start with two reviews that were done, one that we did in 2008 and another by William Miller of MI fame that they did in 2007. And what both of those reviews showed, just by summarizing in narrative form, the randomized trials where they looked at ethnicity as a moderator of treatment effects, they found that, for the most part, ethnicity did not moderate treatment effects. The overwhelming majority of studies that looked at ethnicity as a moderator of treatment effects found no impact. Now, sometimes you do see effects. Sometimes in these ethnicity as moderator studies, you do find that there are differential effects. But about 15 to 23% of these, depending on the review that you look at, find that ethnicity it doesn't have the kind of impact that you expect. It turns out that ethnic minorities sometimes benefit more. And we've done work in our own lab showing this, and it shocked us. And this is just kind of one example of a randomized trial that we developed with one of my students, focused on women at high risk for eating disorders who had kind of significant weight concerns and some other kind of mild symptomatology. So we randomly assigned them to about 270 young women to either this internet-based dissonance-oriented internet-based intervention or an internet-based CBT intervention or no treatment at all. And the dissonance-based intervention focused on having women argue in different ways against the thin ideal. But basically, and that was kind of the core of it. And at post-treatment, we basically found that the DBI intervention and CBT intervention were more effective than no treatment at reducing symptoms and body dissatisfaction. No surprise there. But more important for this talk, we found that ethnic minorities benefited more than Euro-Americans did from the active intervention. And specifically, the DBI and the CBT intervention led to lower eating pathology and depression compared to no intervention for minorities, for ethnic minorities. But there were no intervention effects for white participants. Well, why would this be? We did not develop this intervention specifically for ethnic minorities. We developed this as this broad, kind of CBT-ish, DBI-ish intervention. Well, what we don't know for sure, but the ethnic minority participants in this study were predominantly of East Asian descent. And prior research suggests that East Asian women tend to prefer a lower body weight and are more critical of their bodies on average than Euro-Americans. So one possibility is that the East Asian women of East Asian descent in our sample experience more psychological discomfort and distress than white women did when prompted to argue against the thin ideal. And this resulted in greater dissonance, basically, which we're trying to elicit, essentially. And this greater dissonance may have led to a superior intervention response for Asian American women. So the reason I'm pointing this out is because we developed this kind of what we thought was a generic intervention that counterintuitively appeared to be more effective for women of East Asian descent in our sample. And the reason might have been a good one, but things that we hadn't anticipated, that we had not thought much about. So a student and I, a former student and I, had done something called, we're calling kind of a mega-analysis. So we're looking at a bunch of other meta-analyses that look at ethnicity as a moderator of treatment effects. And overall, we see the same pattern. For the most part, these show no ethnicity effects. Sometimes in these meta-analyses, Euro-Americans benefit more, but other times ethnic minorities benefit more than Euro-Americans do. And we find the same pattern in this annual review paper that we just published within the CBT world, where you get these, basically the results show no significant moderator effects. And somehow that took me to the wrong, there, do that. Okay, there we go. So most of these meta-analyses show no ethnicity effects. When they do show effects, sometimes Euro-Americans benefit more than ethnic minorities. Other times, ethnic minorities benefit more than Euro-Americans. Okay, third question. Does cultural tailoring enhance outcomes for ethnic minorities? So this is complicated. I'm going to try to go through some context here, although we don't have enough time for me to go into great detail, but there are lots of good reasons, lots of excellent theoretical, conceptual, and intuitive reasons to think that culture is important to consider in the context of psychotherapy. It turns out that what I sometimes call the big three ethnic minority groups in this country, Asian Americans, Black African Americans, and Latinx Americans, they all show higher stigma than Euro-Americans when it comes to their perceptions, stigma-related perceptions of having a mental health problem and seeking out treatment when it comes to having mental health problems. So stigma is a significant barrier to seeking out treatment. And then once you get in treatment, it turns out the stigma is a barrier to continuing with treatment and engaging in treatment. So ethnicity-based, culturally based stigma is one really good reason to think that addressing culture in the therapeutic context could be helpful. Help-seeking patterns tend to be different for ethnic minorities compared to Euro-Americans. Ethnic differences in utilization patterns. It turns out that patient preferences differ by ethnicity. Lots of biases when it comes to sort of clinician understandings, perceptions with regard to clients. Most of the best work has been done in medicine. Increasingly, there's more kind of good work in the mental health field. But I think we can kind of extrapolate from what we know in terms of bias in medicine. We've done a lot of work in my lab focused on the mental health correlates of psychopathology and kind of mental health perceptions, work regarding bias, perceived discrimination, and so on. Attrition, dropout from mental health treatment differs by ethnicity. The biggest gap, perhaps, is Black Americans compared to Euro-Americans. The evidence is more equivocal when it comes to other groups, although the data seems to suggest that, say, Latinos and Asian Americans are more likely to drop out too, but again, it's more equivocal. And then there's data suggesting that Blacks and Latinos in particular face greater barriers to treatment access and continuing in treatment. So lots of good kind of reasons to think that culture in the context of therapy should be attended to, should be addressed in some way. So what is culturally responsive treatment? What does it mean to be culturally responsive, to culturally tailored? It turns out that there is no one uniform view. Lots of perspective, lots of theories, lots of frameworks, lots of labels, as I have here. Now, when I give these talks, I usually say, culturally responsive treatment basically refers to any effort to make the intervention, the treatment more responsive or more appropriate for ethnic minorities. And there's a lot of variability in terms of how that happens. I'll skip this. Well, no, I won't skip this. Basically, in the annual review, what I did was just compare these two surveys of clinicians, one carried out in the 1990s by Luis Zayas, and then another by Lorraine Bonito more recently, and asking clinicians kind of how they would define, how they would operationalize, how they think about cultural sensitivity. What do they think it is? And it turns out that clinicians agree amongst themselves generally, and these broad themes emerge, and they've agreed over time. So the surveys done like 25 years apart show a lot of overlap in terms of kind of the broad things that clinicians talk about when they think about what cultural responsivity is, what cultural sensitivity is. And then there are all these models out there. One of the earliest models I was exposed to is by Lloyd Rogler. He published this really important piece in American Psychologist in 1990, basically arguing for cultural responsivity at three levels. The most important level was access, making sure that folks of color had access to services in the language that they spoke, in their communities, so minimizing transportation barriers, say, to getting to treatment. And then the second level was providing interventions, conventional interventions that best fit the perceived needs of folks of color. And some arguments being made that, well, CBT might be particularly appropriate for ethnic minorities because it better mimics what folks might think of when they see a medical professional in terms of kind of the concreteness of it, things that you're supposed to do when you get home, homework, things of that sort. And then at the third level, he talks about modifying traditional treatments to better meet the needs of folks of color. So tweaking, adapting, or modifying in some way. Guillermo Bernal has this kind of cool 8-stage model. Daryl Sue in the 1980s, 1990s developed this tripartite multicultural competencies model. My colleague at just retired from USC, Steve Lopez, developed this really cool shifting cultural lenses model. Pamela Hayes has this really nice comprehensive addressing model with it's basically an acronym for age, developmental level, disabilities. Okay, I've forgotten the other aspects. But basically thinking about all of these different aspects of diversity and finding ways to incorporate it into your intervention in the context of CBT more specifically. Nancy Boyd Franklin, the late Nancy Boyd Franklin, developed this really cool multi-systems model focused specifically on African American, but being applicable to other groups as well. And then in our 2014 paper, and then we kind of reiterated in a recent paper, we argued that cultural competence, cultural tailoring, cultural sensitivity, if you look at the existing models, they tend to fall into these three big chunks. Skills-based models that kind of best fits what we think about when we think about cultural competence, but we have very few rigorous randomized trials to test this. Adaptation models that sort of prioritize this kind of modifying or tweaking, basically, and probably the most research in terms of rigorous trials comparing adapted versus non-adapted interventions. The most rigorous research has been done with this type of model. And then these sort of process models that really focus more on addressing kind of the meaning, cultural meanings within the context of clinical interactions. And I think this one allows the most flexibility but very little research on these sorts of models, at least rigorous research. Now, just in terms of specific things that are recommended in terms of culturally responsive treatment, some pan-minority recommendations that are kind of given across ethnic groups, across cultural groups in the United States, attending to the effects of ethnic minority status or discrimination, assessing the client's experience with racism, ethnic cultural match, providing short-term, time-limited, pragmatic, directive interventions, attending to nonverbal or indirect forms of communication, role induction. Now, one thing I want to emphasize is that these strategies are things that folks have advocated for, but not necessarily things I'm endorsing. And the problem here is that there isn't a lot of good evidence for most of these. Now, role induction is an exception to this. And ethnic match is complicated. So I won't have time to talk about those, but these are things that people have suggested, that they're advocated for, but I just want to be clear, I'm not necessarily advocating for these, except for maybe role induction. And then, others suggest that there are specific things to do with specific ethnic groups. So, and this is just a small sampling of the many things that are recommended for particular groups. So when you're working with African Americans, incorporating spirituality and faith-based coping, given the greater levels of spirituality and religious engagement that you see among African Americans, say, compared to other cultural groups, particularly compared to Euro-Americans. So selected use of African American vernacular English, Black English, or whatever you want to call it, with the caveat that if you're not a native natural speaker yourself, you probably shouldn't do that. It could be more awkward than not. And then for Asian Americans or folks of Asian descent, accepting and tolerating low levels of expressivity, avoiding comments construed as critical or disapproving. This is interesting because I've seen the recommendation go both ways. So for that last one, avoiding comments construed as critical or disapproving, it turns out that in the cultural psychology literature, there's some data suggesting that folks of East Asian descent may be more motivated in response to critical feedback. So some clinicians, some scholars have argued the opposite for Asian Americans. So this is one of those cases where you see recommendations that go in the opposite direction. So avoid critical or disapproving comments when working with Asian Americans, or be more okay using kind of critical, direct, critical feedback when working with Asian Americans. And then for Latinos, involving the family in treatment, using the polite form of you or usted when working with adults. But again, to my knowledge, none of these have been tested empirically in a fairly rigorous way. Okay, that was a lot of context, but I felt we need that context to get to the evidence part. So it turns out that when you look at all the randomized trials out there, that most ethnic minority focused RCTs focused on folks with existing mental health problems, if you look at the past 10 to 15 years, most of the RCTs include interventions that are tweaked or adapted or modified, or there's some cultural element. So cultural tailoring is increasingly the norm when it comes to existing randomized trials with predominantly ethnic minority populations. That's one important factoid. One thing that we did in our 2014 paper is to look at existing meta-analyses that looked at sort of cultural tailoring effects. And what we found is that all of these 10 meta-analyses that we focused on showed that culturally tailored treatment was better than no treatment, better than placebo, and better than treatment as usual. So that's positive. Now, the limitation is that none of those meta-analyses addressed whether cultural tailoring worked better than a generic version of the same treatment. And in our own meta-analysis work, we found a mixed picture. I'm sorry, in our meta-analyses and in our randomized trials. So I'm going to just give you two quick examples of the different stories, the different narratives that you can craft based on the existing data. So this is from our paper in 2008, our review and meta-analysis, focused on kids of color getting evidence-based treatments of one sort or another. And what we found, whether we used a conservative definition or a liberal definition of sort of cultural tailoring, that it didn't seem to matter whether youth of color got a culturally modified intervention or got a standard intervention. Now, again, this is based on what folks reported in the context of the randomized trials or in supplemental materials. So just you have to take it with some grainish of salt. So this is one study showing it doesn't seem to matter. This is another meta-analysis that we did focused on Asian Americans with, in the context of 25 or so randomized trials. And we found that there was an interesting gradient effect. So for those Asian Americans who got an intervention tailored specifically for their particular cultural group. So intervention focused on Cambodian Americans, and the tweaks were Cambodian American focused, focused on Chinese American adaptations, or Vietnamese American. You got the largest effects in those studies, but pretty large, right? So 1.1, which is clearly in the large range. If the intervention was tailored broadly for Asian Americans, not specifically for Chinese Americans, but for Asian Americans, then you got kind of a medium effect. If it was tailored broadly for ethnic minorities, or there was no tailoring at all, then we got something more in the small range. So here we have some evidence that tailoring matters, and the more specific the tailoring, the better the outcome. Now, there are challenges or limitations to both meta-analyses that we have more time I could talk about. But again, meta-analysis telling you two different stories here. Okay. Now, what we decided to do was to try to do a rigorous meta-analysis where we would assess, we would compare, look at randomized trials where they compared a conventional non-adapted intervention for ethnic minorities and compared it directly to a culturally modified version of the same intervention. So pretend that you have like a CBT intervention. You don't modify it all, and you give it to African American with depression, and then you randomize the other half to a culturally modified version of the same CBT, and then you compare outcomes at post-treatment and follow-up. That's essentially the kind of randomized trial that we're looking for in this meta-analysis. We found about 10 studies that did that sort of thing. We put it all together and we found zilch, an effect size of 0.01, indicating that cultural adaptation did not matter when you were working or intervening with ethnic minority folks. Now, keep that in mind because we're going to come back to that in about 5 minutes. All right, so what do we know so far? Therapies are generally effective with ethnic minorities, and this is true in lab-based settings and real-world settings. Lots of evidence-based treatments out there. Many of them focused on Black and Latinx populations, but increasingly for Asian Americans, we're working on another meta-analysis focused on indigenous populations around the world. Turns out that in many European countries, they have more and more trials that highlight the efficacy of interventions for ethnic minorities in, say, Finland, in the Netherlands, in Norway, in the UK, in Germany. So we're accumulating data suggesting that, well, ethnic minorities across the world can benefit from these conventional interventions. They're mostly CBTs, but not exclusively. That's my timer, suggesting I need to speed things up a bit. Ethnic minorities and Euro-Americans mostly benefit equally, and cultural tailoring doesn't appear to reliably enhance treatment effects. Well, what about other aspects of diversity? So I've been focusing on race and ethnicity, but those are not the only things that define us, believe it or not. So all of us have these intersecting identities. So for example, I'm a Black male professor, a citizen of the United States, and like we pointed out, I'm a Californian, born and raised. But with cultural roots in rural Mississippi and rural Louisiana, and I'm also an atheist, a father, and a psychologist who's married to another psychologist, and that's for starters, right? If I'm being treated for a mental health problem, are these identities even relevant to any clinical encounters that I might have in relation to to my mental health concerns. So and those are the identities that I just kind of highlighted. Think about all these other salient and relevant identities. How do you think about these things? And do you think about these things in the context of intervention? So does culture matter? Does cultural tailoring matter? Well, I think the answer is yes. And I don't know if counting sheep actually makes a difference or really helps when you're trying to sleep, but I think we can kind of agree that's probably not going to be a helpful strategy for the lion. So I think, like many things in life, things are complicated. So we all understand that tailoring in some form can be helpful, maybe even necessary to address certain conditions, identities, and experiences of our patients. So what does this all mean? Kind of what do we do? How do we think about this? So I'm going to quickly go through sort of 5 lessons that I kind of learned in 20 plus years of doing this. First, successful culture responsive treatment might be redundant with what many clinicians do naturally. This is in that 2014 paper, we summarized data from 5 different surveys of mental health professionals. And all of these surveys showed that clinicians generally say that when they work with culturally diverse folks, that they tweak, adapt, or modify to take that into account, and or they indicate that they're culturally competent and that they're able to work effectively with diverse folks. Now, what it is that they're doing when they're working with diverse folks, whether it's useful, whether it's effective, it's hard to say from the survey data. But the fact of the matter is that clinicians, by and large, they feel that they're able to work with diverse folks, and they say that when they work with diverse folks, they take that into account. They do stuff. So even if in the context of a randomized trial, we have this so-called generic intervention that has no discernible cultural elements embedded within it, it doesn't mean that the clinicians aren't doing their own tailoring based on their own perceptions of the needs of the client. So when we call a treatment a generic treatment or a non-adaptive one, that may be a misnomer because the clinicians are doing that tailoring on their own. Again, we don't necessarily know what it looks like, although there's some emerging data suggesting that we have some ideas. Okay, great, thank you. So that's one lesson. Then there's the notion of equifinality, and this is data suggesting that culturally diverse clients might wind up might take different paths to get to the same place. And I don't have time to talk about this, but you know what? I do have time to jump ahead to that. And no, I don't. Jump that. Okay. If anyone wants to ask me about equifinality later, we can talk about that. Third point, culture responsivity effects might vary by acculturation status. So we is one example. We did this phobia intervention a while ago. We randomly assigned folks, Asian American students with phobias, animal phobias, mostly spider phobias, not exclusively, to get a standard one-session intervention developed by this Swedish researcher named Lars Goran Ost. And they got the standard intervention, or they got randomized to the culturally modified version of the intervention, but including some subtle modifications, or to a self-help intervention. And what we found, spiders, sorry, if any of you are spider phobic, I should have warned you in advance, my apologies. We found that both active interventions were more effective than self-help in reducing phobia symptoms. They're highly effective. But we found that the culturally modified version was somewhat more effective, just a bit more effective in terms of our significance level on some outcome domains. But more importantly, for my point, is that the effects were moderated by acculturation status. So those who were most closely identified with their Asian American identity, they benefited the most from the adapted intervention. Those who were more mainstreamed and less Asian identified, they benefited more from the more generic version of the intervention. So that kind of makes intuitive sense. So acculturation status may be a salient factor when we're thinking about the utility of cultural tailoring. Another important point, and I think this is a really important one, is that cultural tailoring can help in some circumstances and it can harm in others. So remember that figure, that data point I showed you before, the comparing tailored versus non-tailored interventions, an effect size of 0.01, a negligible effect. It turns out that there's a lot of variation here. It turns out that sometimes in the context of these trials, you find that cultural tailoring helps. It does enhance outcomes. But other times it seems to harm. It seems that you would be better off not doing the tailoring. Essentially. And other times it's more inert. It doesn't seem to make that much of a difference. So the point is that cultural tailoring can help, it can harm, or it can be inert. And it would help to kind of know what those parameters are and why that's the case. And some scholars have argued, made some kind of interesting theoretical arguments about why this might be. I'm going to focus on this last one. The second one, that less activation of change mechanisms. So one argument that some folks make is that when you tailor, you tweak, or modify, you have to be mindful or careful because it might distract from core treatment strategies that get you the most bang for your buck. So if you're a phobia interventionist or a PTSD interventionist and you do exposure, or PTSD, prolonged exposure, one thing that a lot of research suggests is that the exposure part is the thing that's kind of core, that gets you the most bang for your buck. So if you're doing less exposure and more other stuff that you are adopting because you think that fits with a more culturally tuned process, it could be helpful, or it could be removing some of the active stuff that helps to move the client forward in important ways. So cultural tailoring, ironically, in some cases, might create these inefficiencies with treatment. It might interfere with some of these active ingredients, the things that we think are going to get us the biggest bang for our buck. I'm going to skip that, skip that. I skipped too much. Final point, lesson, I should say. Effective culturally responsive treatment might challenge conventional notions about what matters when addressing diversity. I have become a lot more humble in terms of what I know, what I understand about what matters when it comes to intervening with ethnic minorities. And one of the studies that's kind of helped me to kind of think about this is this really cool study by Emil done more than a decade ago. And it kind of highlighted that we don't know what reliably makes therapists more or less effective with ethnic minorities. But this study kind of clarified that you can get a lot of variation in clinician effectiveness. So what Emil found in the context of this randomized trial focused on folks with substance use problems is that clinicians vary dramatically in terms of their effectiveness. Clinicians doing the same intervention with the same broad population, different in terms of their broad efficacy and different in terms of how effective they were with Euro-Americans versus ethnic minorities. So what they found, for example, is that you got some clinicians who were really good. They got great outcomes. So the lower the bar, the better the post-treatment outcome. And so these clinicians on the left are doing a great job, but you see they tend to be doing a great job with everyone, right? There's not a lot of variation in their outcomes for minorities versus Euro-Americans. Where you see the variation is with the clinicians who are not doing that well. And when they're not doing that well, you tend to see more outcomes that maybe are more likely to benefit Euro-Americans, or they're just variations. So some are more likely to do well with ethnic minorities. So, but the clinicians who are really good, they tend to be good with everyone. So one of the things that I've been thinking about more recently is how do we reverse engineer this? How do we find out who these clinicians are and kind of what's sort of happening? Okay, I'm going to do like the 2 or 3 minute wrap up. Okay, thank you. So are tailoring strategies okay? Well, just some examples of different things that folks have kind of advocated for. I would say maybe. I have some ideas. So one is the reverse engineering idea that I kind of mentioned, like really diving into what clinicians are doing, tracking the outcomes that they're getting in these real world contexts, whether they're getting differential outcomes for ethnic minorities versus Euro-Americans, and then trying to discern what the superstar clinicians are doing versus the clinicians who are struggling more. And once we figure that out, we kind of bottle that, refine it, and see if we can train other clinicians to do those things that differentiate them. So this is reverse engineering the process. Increasingly, I've been talking about these broad strategies that are neutral in terms of their cultural focus, but they seem to be good strategies that we know work in terms of engagement and getting good outcomes. So doing things like in the initial sessions where you ask a lot about potential barriers to treatment and you work to problem solve with the client how to reduce those barriers. Orienting clients to what therapy is all about, to the culture of treatment, given that ethnic minorities are less likely to understand the intricacies of therapy, the culture of therapy, and given that role induction, orienting them, helping address misconceptions seem to help in terms of engagement and outcomes, doing that with everyone. And we might get it might be particularly effective with ethnic minorities. Attendance prompts, sending text, email, maybe even letter prompts to folks before sessions. Like for every medical appointment, that's what happens with me. Oops. And then measurement-based care, tracking outcomes, personalized care, active expert supervision. And then we're in the process of writing a paper where I'm creating these rules of thumb for cultural tailoring. And basically 4 key points. Tailoring when your assessment justifies it. Consider tailoring when barriers to treatment progress arise. Using tailoring strategies that minimize interference with your active ingredients. And then approaching tailoring as hypothesis testing, not an assumption. And maybe you can start with it as an assumption, but as long as you're collecting data and then thinking in terms of hypothesis testing, looking at your data as it comes in and seeing whether this tailored strategy that you're using is working or not, and then making adjustments along the way if it's not working, I think is the way to go. Okay, thank you very much.